Welcome to Eye Contact, a video news programme on issues and controversies in ophthalmology sponsored by EUROTIMES. I'm Paul Rosen and we're here at the 32nd Congress of the ESCRS in London, which is being held in conjunction with the 14th EU Retina Congress. Today we'll be talking about submacular hemorrhage with Francesco Bandello. Professor Bandello is Professor of Ophthalmology at the University Vita Salute, Scientific Institute San Raffaele in Milan, Italy. He's also the current President of EU Retina. Professor Bandello, welcome. It's a great pleasure to have you here.
Hello.
Professor Bandello, thanks very much for joining us. And I understand you gave a presentation today on submacular hemorrhages and the management. I just wondered if you can do a brief summary of that presentation and your views.
Macular hemorrhage can be a complication for 5 to 10% of patients with AMD, wet AMD. And this is a very bad complication because the blood is able to produce damages to the photoreceptors and to the different retinal layers. Because of that, you need to try to stop the hemorrhage and to make some kind of reabsorption for the blood. And this is possible today, I think, using anti-VEGF. Anti-VEGF are surely able to close the new vessels and to produce some kind of stop in the bleeding, and reabsorption of the blood will then allow to have also a recovery of the retinal function. Unfortunately, this is possible only for cases where the hemorrhage inside the retina is not very thick. When the retina is with a large amount of blood, anti-VEGF alone maybe are not enough to solve the problem. So in these cases you need something else, and something else can be TPA. We mentioned some study where TPA was used, and it was shown that TPA is able to reach the deep layers of the retina only if you go inside the retina. So if you inject TPA inside the vitreous body, you are unable to have enough amount of drug at the level of the target tissue. So what you need is to inject TPA inside the retina and then to produce some kind of reabsorption of the blood.
What are the indications for vitrectomy and subretinal TPA?
So on the basis of the experience and on the basis of the literature data, you can use anti-VEGF only when the amount of blood is limited. But whenever you have a lot of blood inside the retina, you need to make a surgery.
Can you give me some indication as to what a lot of blood is? So how will I know when to do a vitrectomy? And,
I think the best way is to evaluate clinically the thickness of the blood inside the retina. And if you have a layer of blood, you can for sure use only anti-VEGF. Whenever you have a thick amount of blood, and it is difficult to say a measure of that, the anti-VEGF is not enough to solve the problem.
And do you think timing of the surgery is important?
Absolutely, yes.
So how long have we got from
whenever
the appearance?
you're right. One of the problem is that if you are late with your surgery, you can anyway have a dramatic visual loss because of the damage already produced by the blood. And the effect of blood is direct, is toxic on the photoreceptors, and it is also mediated. But anyway, if you have a thick amount of blood, I think that the surgery must be done as soon as possible.
Okay. And well, in a lot of healthcare economies, there's this big issue of the logistics of providing anti-VEGF services for patients with macular degeneration. What do you see as the long-term treatment for neovascular AMD? Is it always going to be injections, or are there going to be alternatives which are going to be easier to deliver?
I think we had during these last years this kind of revolution because the anti-VEGF, the intravitreal therapies were able to modify the prognosis and for a lot of patients with vascular diseases of the eye or AMD. And for sure, this was able to make some problem to the organization of our systems. For sure, United States and Europe are different from the organizational point of view. It's common in the United States to do intravitreal injection in an outpatient service and in the office. This is not the case for Europe. In a large part of countries in Europe, intravitreal injections are still done inside the theater, which means that you have really a lot of patients, a number of people, because patients are together with the family, one, two, it depends if they are from the south of Italy, they are with 3, 4 family members, and you have hundreds of people that you need to manage in some way inside your service, and this can become really a huge problem for us. Please.
Who do you think should be giving the injections? Should it be the surgeon or should it be a nurse technician?
We are doing injections, the doctors, and we do not have any technicians allowed to do something like that in our country and in Europe, generally speaking. I think that the country which is more sensitive to this can be Great Britain, because they have a number of eye doctors which is low in comparison with the other European countries, and they are used to delegate to some kind of technician also maneuver that usually are done by doctors in the other countries. In Italy we have 6,000 eye doctors for 60 million people, and in UK you have, if I know well, 1,000 eye doctors for the same population. So the relationship between the number of eye doctors and population is completely different. So that's the reason why they need to delegate to somebody else.
Do you think it's always going to be an injectable form of treatment, or can you see in the next 3 to 5 years there could be either topical or oral medication, which would make the process so much easier?
Yes, for sure. I think that what we are now living is a phase that will end in some year. Maybe we will use some kind of long time release of the different compounds, or we will have some kind of eye drop which will be able to produce similar results. Although I must say, as an eye doctor, I am a little bit concerned about the future of eye drops instead of injections. I think that if we will lose the how do you say, the handling of
the involvement with
the
patients,
direct involvement, this can be a problem for us, because we are now settled down in our departments, in our services, for having a lot of maneuvers, procedures, patients, and if this will be done by GPs or any other doctor or by eye drops, this can be a problem for us, and we will live a very bad time in comparison with this.
Professor Bandello, thank you very much for joining us. For more information on this and related topics, please visit us at eurotimes.org.